I've shown a lot of cases in the past, but I thought today I'm going to talk about doing jaw problems and at the same time being a general dentist. And we need both to treat, because if you're not a well-versed general dentist, you need the knowledge and the skills. You need to diagnose, you need to have the knowledge, and you need the knowledge to treat, and you have to be a very precise dentist. Sometimes we refer to oral surgeons and orthodontists because some cases require that. And in some cases, even some cases, you need an orthodontist, an oral surgeon, and a restorative dentist. So it can be complicated, but you have to have the knowledge and the skill to go after the diagnosis. It's in the diagnosis. You can't treat what you don't know. The combination of constant continuing ed and years of experience are a great asset in diagnosing TMJ and the other dental problems. TMJ is also called TMD by dentists but everyone says TMJ, so that's what I talk to patients about. But TMD means temporal mandibular disorders, which includes muscle disorders related to jaw problems. What isn't it? 4 patients in 40 years had symptoms similar to TMJ, very severe pain in the face, but it turns out it was in fact a condition called trigeminal neuralgia, and that's a nerve irritation that really hurts, but it has nothing to do with jaw problems, but it sometimes mimics it. Then we had a patient that had a lump on the side of his face, and he said, he showed it to me, and he said, it's there and it's kind of big. And I said, well, I touched this, it's not a fat tumor. And I think you have to see another doctor and get a second opinion, because I don't think that it's nothing. The first physician said it's nothing. I said, no, this is an area where there shouldn't be anything there. And that's where the background comes in. I knew all the things that could happen there, but the lump wasn't one of them. So it turns out it was cancer. And so he's alive today. So I told him, you owe me big time every time you owe me big time.
Wow.
He went through a lot of treatment, and it looks like he had a stroke, his face sagged after the surgery and everything, but then he's fine. So you have to have a thorough knowledge of TMJ and general dentistry to spot unusual symptoms and make appropriate referrals. So diagnosis requires knowledge. This knowledge must be earned. Treatment requires expertise in performing certain dental procedures. Accuracy is essential. Anyone can talk about jaw problems. They can say, this is what you're supposed to do, this is the solution, blah, blah, blah. But who can actually perform it? You can talk the talk, but you have to walk the walk. TMJ or toothache. Patient presented with a toothache and possible jaw ache. He said he thought he had TMJ. And examination, x-rays, photographs showed he had a cracked tooth and a slightly crooked bite. And that's why he was uncomfortable, but it wasn't TMJ. So the treatment was adjusting the bite, restoring the cracked tooth, and adding composite to a tooth that could have been moved with orthodontic treatment, but at his age he didn't want orthodontics, so I added material to the back of the eye tooth to make it function correctly, and the pain went away. And so if you look, this is where I added the composite. This is another look, but this angle and this angle have to be the same. And so that's the way it looked when I got done. So if you looked at the patient from the outside, you could never see it. But the pain stopped that day. So again, sometimes we add, the green is where we add composites, where we add composite to the teeth, and then correct the bite. So these are all areas where I'm adding to make the bite correct. And sometimes we use movies.
With a bite like Jenny's, she's bound to have problems her whole life, even without a car accident. Car accident probably started the ball rolling earlier. She has some terrible bite issues that have to be fixed. Number one, when Jenny bites,
See, look here.
the way her jaw moves normally, she hits on the back teeth. She hits,
See?
slides forward,
Yeah.
and these condyles this ways.
That's a, but I do, that's my own protocol, because I use that to teach dentists about what causes jaw problems, but the patients love it also. So it's great. And then I do my own lab work doing it. I don't send it out, I do it myself. And it requires high level of competency, especially when we're changing bites. This is a very unusual case where she's missing her eye teeth. And so I made the bicuspids function like eye teeth, and that made her comfortable. So relieving pain uplifts. When we get a patient out of pain, whether it's from teeth, gums, or TMD, it uplifts the morale of the entire office. It takes a knowledge of general dentistry and TMJ. When a patient comes in with pain and leaves without it, it is a happy moment for all. Thanks for listening. You have all seen my other successful cases now. Any questions?
Do you do Invisalign in your office?
No. I took the course. I took the Invisalign course, and what I found out, it has many limitations. And one thing you have to do in the Invisalign, you have to remove a lot of tooth structure. And I'd rather have a patient go to an orthodontist where they could move the teeth and take away less tooth structure. And I thought I would use Invisalign to move teeth for my TMJ patients, but it turns out it's limited when you have to twist the tooth or something. And it costs just as much as going to an orthodontist. The lab fee for the Invisalign, for whoever does it, general dentist, orthodontist, is over $2,000. That's before we make anything. So I said, I felt it would be better for the patient to go to a conventionally trained orthodontist. They would get possibly better care. And it can be done quicker if they use a little bit of braces.
Dr. Mark? Oh.
Sean?
No, Gene.
Oh, I'm sorry, yes. At what age does a child need to start seeing a dentist, and do you treat children?
Oh, yes.
At what age do you think they should start coming in?
3.5 to 5.
Oh, to 5.
In that area.
And you don't really clean their teeth, do you? Or you just look at them or evaluate them?
Well, no, it's with the dental hygienist. It's like a mother figure, so they get used to a woman, doing it and being nice to them. And sometimes children have bad experiences with people in white coats. And so if you have them to go to the hygienist will get the instrument and rub the teeth a little, get them used to having things in their mouth, and making friends, and showing them it's not painful. The worst thing you can do is show concern when your child is going to the dentist, and if you look like you're saying goodbye to them, they're going to execute them.
See all that equipment.
Those are the kids that cry in the waiting room. When they cry in the waiting room, that means the parents have done a great job of scaring the shit out of them. So it's not a good way. Just be very positive and say, oh, they're going to be nice to you, blah, blah, blah. Yeah, so, and then don't wait till they have a problem or they have pain and they need drugs, injections and everything.
Thank you.
Glenn?
What's the latest new materials? Are any of them better than gold?
Diamond.
Self-serving.
Gold? That's an excellent question. Dentist 46 years. Gold is still the very best restorative material you can get.
Yeah.
Because it wears gently, it bends a little when you bite on it. It doesn't pound the teeth like porcelain or zirconia. Zirconia is really strong, but when you bite, it's a hard tap on your teeth. And some people, they must have it because it's white. But gold is still the best, and in my experience, the longest restoration, the longest in-the-mouth restoration I've seen for my whole dental career are gold. I've seen gold crowns in 40 years. Me too.